All right, so next up in the program, we have Dr. Keith Starnes from the Mayo Clinic, who's going to speak to us about neurostimulation in Dravet syndrome.
All right, hello. Thank you to the organizers for having me here. I'm very happy to be here to talk about this important topic. So these are my disclosures. I don't have any financial relationships with any device companies, but everything that I'm going to be talking about is off-label, so just know that up front. So we'll first define what we mean by neuromodulation, especially in the context of epilepsy and Dravet syndrome. And then we'll talk about how you deliver that. And we'll talk about some of those devices that are listed there. We'll talk about what scant evidence is out there for the treatment of Dravet syndrome with neuromodulation. And we will wrap up by looking toward the future and what might be coming in this avenue. So when we talk about neuromodulation in the context of epilepsy, it refers to the application of electricity to the nervous system with the goal of reducing seizures. And that can be, usually we're thinking about reducing the frequency of seizures, of course, but even when seizures occur, hopefully reducing the severity. And this can be done either surgically, which we refer to as invasive, or non-surgically, which we call non-invasive. It doesn't permanently alter the brain structure as opposed to things like epilepsy surgery or destructive surgery, which we often think about for other people with epilepsy, which means in most cases it's entirely reversible. The ultimate goal, of course, is the improvement of quality of life. Usually that goes hand in hand with decrease in seizures, but not always, and we try to think about ways to measure that as well. An important thing to know about neuromodulation, neurostimulation in general, is that it very uncommonly makes people seizure-free. So that's sort of a baseline thing to know, but we'll talk about how close we can get, and we're always trying to get as close as we can. So what's depicted here is just a circuit diagram with the brain, and that's pretty much what we do with neurostimulation. It's a bit of an oversimplification in some cases, but many times it's about what it is. So it ties into this term that of bioelectronic medicine, which is this fancy term we use, but I think it's appropriate because the nervous system operates on electricity. When you do an EEG, that's what you're measuring. You're measuring fluctuations in electrical activity and different electrical potentials. And you can use electricity. This has been shown not only in epilepsy, but just in other neurological diseases, but especially in epilepsy. You can use electricity applied to the nervous system to do a number of things, including interrogate the nervous system, see how things react, and that can tell you something about the brain or other systems, to modulate or decrease activity, or to amplify brain activity. And the way that you deliver stimulation really determines what the outcome is going to be, or which of these you're trying to do. Of course, in epilepsy, most of the time, epilepsy is essentially a disease of overexcitability. It's a little bit too easy for the neurons to fire. So in epilepsy, most of the time what we're trying to do is make that harder to do, so we try to modulate or decrease electrical activity. So we'll be talking about inhibitory electrical stimulation. And a few key concepts that I think are important as we go through this. We are constantly asking ourselves how stimulation should be delivered, and that applies to a number of domains, but timing is very important. And you may hear about these concepts of closed or open loop stimulation. That basically just means it's a closed system, which means there's a switch that gets turned on or off depending upon the set of conditions in the environment. So that's sometimes referred to as responsive neurostimulation. Commercially, there's this device called, from this company called NeuroPace that makes this device, the responsive neurostimulator, not really used for Dravet syndrome. Versus open loop, which is just continuous stimulation given all the time, kind of regardless of what's going on. Most devices that we'll talk about are primarily delivered that way, but there's a couple nuances with that. So the other is the frequency and the time scale that you give the stimulation. Do you give it in a continuous fashion? Do you give it on a cycling fashion? We'll get into that a little bit too. And then the location is a very important question. Where do you stimulate in the nervous system? It turns out there's a number of different targets, and it probably matters on an individual patient level where you give that stimulation. And then also the seizure types that you're trying to address, that also determines where you're stimulating. And again, the goals that I just talked about on the last slide. So on the bottom here is this is just a conceptual framework. It's not based on real patient data, but it's just this way of thinking about things. Moving left to right is time, and up or down is seizure probability. So what we know is that many patients, and actually quite commonly in Dravet syndrome, there is a cyclic pattern to seizures. It can be circadian, occurring on a daily basis, or what we call motidian, multiple days, or it can be weekly, monthly, and many of you may have even noticed that in some of your family members. And the idea there is there's this fluctuation in seizure probability states, and these orange dots here represent seizure events. And so, as you might expect, when the patient's in a higher seizure probability state, they're going to have more seizures. With responsive neurostimulation, the idea is more stimulation is delivered during those times of high seizure probability. And that's what those green tick marks represent. And so you essentially chop off those periods of high seizure probability, and the end result is the patient spends less time in high seizure probability states and ultimately has fewer seizures, ideally. With continuous stimulation, the idea is a little bit different. You give stimulation all the time, no matter what's going on, and you shift the whole curve down. So the patient ends up having fewer seizures for the same reason, but just what's going on underneath is a little bit different. It's not that one is inherently better than the other, but this is just, it's important to think about. The other thing I wanted to mention here briefly is what's shown on the right is when you put electrodes into the brain, or when you stimulate the brain, as I said earlier, we're basically completing a circuit, and by convention, current flows from positive to negative. So it turns out you can change where the positives and negatives are on each electrode you put in, and you can generate currents not only on those same electrodes, but if you have the electrodes close enough to each other, you're also generating currents between them. And this is actually an oversimplification. It is a lot more complex than that. And so it means a couple of things. One, you just have to be aware of that when you're programming. But two, it means there's a lot of different things you can do. I mean, even with two electrodes, you can, without moving them, you can program to provide a lot of different stimulation. So this is a schematic of some of the devices that are out there to deliver neurostimulation. On the left, in the pink shaded box, are the invasive options, which require surgery. The two we'll be talking about are VNS, or vagus nerve stimulation, which you can see there's a battery here in the chest, and then a wire runs up. It connects to the vagus nerve here on the left side of the neck. And then DBS, which is also usually actually the battery's on the right side. It's on the left in this diagram, but it doesn't really matter. But the wires go into the thalamus, which are these structures that are deep in the middle of the part of the brain. And so you have wires, kind of anchoring electrodes up here, and then penetrating electrodes that go down into the thalamus. And we won't be talking much about RNS or CSES, and I'll explain why as we go on. And on the right are the non-invasive brain stimulation options, which don't require surgery. And we'll be talking about a few of these, the TDCS, which is transcranial direct current stimulation, TMS, which is transcranial magnetic stimulation, and then transcutaneous or transauricular vagus nerve stimulation, where you can actually stimulate the vagus nerve through the ear. And this is how I like to think about it, both in terms of invasive and non-invasive, and targeted or non-targeted. And what this means here is targeted means you have to have at least some idea where the seizures are coming from. And in Dravet, it can be a little bit tricky. And the degree to which you need to know that, or the precision to which you need to know that, depends a little bit. For RNS and CSCS, which is continuous cortical stimulation, you need to know that pretty precisely, we think. For the others, maybe, maybe not, and we'll get into that. So first, we'll talk about the invasive brain stimulation techniques. So this is all of them, or most of them, depicted on one brain. You're not going to see this. There aren't really any patients that have all four of these, that I know of anyway. But the two we'll be talking about are VNS, depicted there in the vagus nerve, and the DBS. The other two are implanted directly on the cortex of the surface of the brain where the seizures are coming from, which is part of the reason why it's a little bit tricky to use in Dravet, or would be theoretically tricky to use. So this is the VNS. There it is depicted again with a kind of inset there showing how the wires wrap around the vagus and the nerve, the vagus and the neck. And on the right, you don't need to know the technical aspects of this, but that's a diagram showing that how the vagus nerve works. So seizures don't come from the vagus nerve. The vagus nerve isn't even in the brain, but it projects up into the brain. And so the idea is you give stimulation that then gets projected up. Actually, gets projected down a little bit, but mostly up, and goes into these different areas of the brain that stimulate the production of these chemicals, which have an anti-seizure effect. That's how the VNS is at least one of the major reasons it's theorized to work. In most studies, over the long term, the response rate is 50%, roughly. And when I talk about responders, when anyone talks about response rate with neurostimulation, what that means is patients who have at least a 50% reduction in their seizures, meaning 50% or more. And in the randomized controlled trials back when this was approved, which you can see the dates there, over 30 years ago, the response rate was only about 20 to 30%, but they only looked out about 3 to 6 months, depending on the study. And it turns out, as I'll show you, the longer you look, the better patients do. But in general, what people have found is that the response rate is about 50%. Easy to remember, 50% of the time seizures are cut by 50%. The vagus nerve has a branch that comes off of it that goes to the vocal cords. So the most common side effect is when it fires, the kids or whoever it is, the patient can feel a little bit tingling. Sometimes it causes some hoarseness in their voice if they talk when it's firing. Occasionally it can cause some difficulty with swallowing, coughing, or pain. If those really become problematic, then most of the time we can adjust the settings such that they aren't issues anymore. But most people do quite well with the VNS in terms of side effects. So this is the best studied modality for nerve stimulation in Dravet syndrome. So a couple years ago, this group did a meta-analysis, which is basically pulling a bunch of different studies that have been published to look and see how people had done with this. And there were 107 patients out of these 15 studies, and what they found was that 60 of them had a 50% reduction in seizures, so about 56%, pretty in line with what I told you. They also said that 8 of them were seizure-free. I have to tell you, in my experience, that's a bit surprising that there were that many. I think in real life, over the long term, you're probably not going to see that from neurostimulation alone. Not that it never happens, but it's quite uncommon. Now, with meta-analysis, I think it's important to point out a couple of things. One, this is pulling together a bunch of what we call case series or case reports, meaning the way that the studies were done could be varied in each case. They're published by different authors from different institutions. The way that they count seizures varied from study to study. Sometimes they counted all seizures, sometimes they counted only the most disabling seizures. They didn't always look at quality of life or other measurements. And there's also something about doing studies in this way where you can imagine if you treat 3 patients with the VNS and only one of them does well or none of them do well, you may be a bit less likely to want to publish that. I don't think that there's people are hiding things or things like that, but just that's the human nature. So there's a bit of a caveat with the meta-analysis, but still, I think that number, about 50% reduction, is fairly reliable. Again, hoarseness was the most common side effect. So to shift gears and talk about DBS, and from here on out, everything I'm going to be telling you is, again, kind of limited to really small case series, and I'll try to point that out. But DBS, there aren't any large clinical trials for this with Dravet in adults with focal epilepsy. There was a 75% reduction in seizures at 10 years. And again, a meta-analysis from a few years back looking at 40 peds patients, none of them had Dravet. There was 85% of them had at least some seizure reduction, and 13% of them were seizure-free. This included 13 patients with Lennox-Gastaut syndrome, another developmental and epileptic encephalopathy. But this didn't get into how much seizure reduction they had, just that all of them had some benefit. And more recently, there was a trial in pediatrics looking at Lennox-Gastaut patients in 19 of those, and there was a 47% seizure reduction. So deep brain stimulation also is pretty well tolerated. Most people do quite well with it. There can be some implant pain just from the surgery itself. Usually that's self-limited. In the clinical trial in adults, compared to the sham group, which is not getting stimulation, the group that got active stimulation reported memory impairment more commonly. On objective measurements, that didn't actually hold up. And the same is true for depression. However, we do see clinically that there are some mood effects with deep brain stimulation. And now, of course, depression, anxiety, these are very common. These are extremely common in people with epilepsy. So it's not an absolute contraindication to receiving deep brain stimulation, but it's something to be aware of. And it turns out that if it does occur, if you find that the patient is having worsening mood, oftentimes you can adjust the settings such that that isn't so much of a problem. So deep brain stimulation, as I mentioned, is, at least as it applies to epilepsy, refers to stimulation of the thalamus. And the thalamus has an interesting role in Dravet. And so the upper left there is just highlighting what the thalamus is and where it is. There's a right and a left, thalami, two of them. And on the right, these are from actually mouse models of Dravet. So we don't have to get into all this, but I just wanted to point out in the lower right that there are alterations in a neuronal excitability in the thalamus in Dravet, but the way that things are altered depends on where you look in the thalamus. So in some areas, one area called the reticular thalamus, there is decreased excitability in Dravet as compared to typical controls. And in the ventroposterior lateral thalamus, there's increased excitability. So where you stimulate probably matters, and the effect of your stimulation is also going to matter, even within the thalamus, which is already a small structure. On the left is what is shown there, some of the targets that we often think about when we're doing deep brain stimulation. So there's very little evidence in Dravet. Dr. Andrade, who you heard from earlier today, actually published a study a while back from 2 adult patients who had a 90% seizure reduction, one of whom did well initially after a year or so, and the other patient who took another surgery to move the electrodes around and eventually did quite well. And then more recently, there was the group from UT Houston reported on a patient that they treated that did quite well. And they actually, what was another unique thing about that paper was that they used some of the newer DBS devices allow you to do sensing or measure EEG from the thalamus, and they were actually able to quantify that patient's seizures. Now, the DBS doesn't respond, it just measures, but they were able to quantify the patient's seizures, over the long term, and found that patient also had circadian cycling. And as I mentioned, the efficacy improves over time. So on the left, these are actually all DBS patients. This is from a single center looking at over time with VNS patients. I believe this is in 20 patients. And what they found was that if you go out 3 years, the response rate is about 60%, or the seizure reduction is about 60%. But if you look after a year, it's much lower than that. So there's something about Dravet even more pronounced than other conditions. On the right is DBS and RNS. Showing the same effect, although it's not quite to that same degree. So I think there's something about Dravet, and this has been published a few times, that it takes a while to really see the benefit, even more so than other epilepsies. With that said, Dravet is certainly a heterogeneous condition, and and as I think this ties in nicely to the last talk, there's a lot of variability in Dravet, and it represents a unique challenge in stimulation. So this is a nice study from a few years ago. This group in Germany, they did simultaneous EEG and functional MRI recordings looking at blood flow in different states. And this has been used in other epilepsy conditions, other epileptic encephalopathies even, like Lennox-Gastaut, and has led to us being able to really target those in a more precise way. But with Dravet, in these 10 patients, all with similar SCN1A mutations, there were no common patterns observed. There were thalamic activations in 3 of them, but that's a minority. And so it's a little bit hard to make sweeping statements about this. And this is looking at fMRI at the time of spikes. And spikes can vary, the location of spikes can vary in Dravet, so that makes stimulation a bit of a challenge. So now, for the remainder of the talk, I'll discuss non-invasive brain stimulation, and that has several advantages. One, of course, the most obvious is that there's no surgery required, which means it's reversible. They tend to be very safe. Most of these, when studied, are considered to be minimal risk by the FDA. TMS, which I'll talk about, can actually target using the patient's own MRI, and TDCS can be used actually at home. So this is what TMS looks like. This is an adult, obviously, but she is sitting in the chair. That's her MRI on the screen, and you can use the one to kind of target where the stimulation goes. So the way the TMS works is by activating a pretty small volume of tissue. As I have written there, it's a cylindrical volume, only about 2 cubic centimeters. So what that means is you have to really know to a reasonable degree what you're stimulating and where. This is a potential therapeutic option. Most of the time when we use it in epilepsy, we're actually using it for mapping. You can stimulate different areas and map out motor and language function pretty well with it. But it does have a potential as a therapeutic option. Turns out low frequency stimulation is inhibitory. So we're starting to explore that. And as I touched on earlier, you can probe the nervous system using brain stimulation. So TMS EEG, so performing TMS at the same time as EEG, you can stimulate one site and see how the rest of the brain reacts. And that can often tell you something about the brain's connectivity and something about the patient's state. There are no human studies in Dravet. This is in a mouse model showing that there was a decrease in seizures. Now, with 2 cubic centimeters in a mouse's brain is a lot more than it is in a human brain, but still, there's potential there. There are studies that are enrolling, and as I mentioned before, probably the greater potential, at least for now, in the immediate future, I think is going to be interrogating networks with TMS. So transcranial direct current stimulation, TDCS, there's a lot of S's, of course, that is a comparatively simpler technology. It uses, I often say, it's a couple 9-volt batteries, it's a couple wires and a couple sponges, and that's about it. You kind of hook them up to the patient's brain or to the patient's skull, and it just is depicted there on the bottom. And it's a very low amplitude current that we use. It's so low, in fact, that it doesn't tend to cause neurons to fire. But we think that it decreases the likelihood of them firing, and that's how it exerts its effect. It's a comparatively larger volume of tissue, so it's less intense than TMS, but it's a larger volume, so on the order of tens of cubic centimeters. Very safe. Thousands of patients have been treated with this, including thousands of children. Kind of the worst thing that can happen if it's done properly is it'll irritate the skin, cause some redness. It goes away after about 20 or 30 minutes. It can be done at the bedside or even at home. We've done that, not in Dravet, but we've done that in other families. And unfortunately, if you type TDCS and Dravet into PubMed, this is what you get, nothing. But I think probably that's going to change in the next few years. And the last device I'll talk about is this is a single case from about almost 10 years ago. This non-invasive VNS, or transcutaneous transauricular VNS, from this device that's available in Europe, not in the US yet, unfortunately. But this was a patient who tried lots of different meds, as you can see there. She even tried keto diet. And doing this transauricular VNS for 4 hours a day for 4 months reduced her seizures from 30 a month to 13 a month. So, a significant benefit there. Of course, this is only one study, but I think there's certainly potential to look into this further. And the bottom line with all of this is it's very safe. There are, of course, regulatory issues with this. This device isn't available in the U.S., and there are some other limits with that too. But as we go forward, I think there's going to be probably a couple different avenues that will be explored, and I think probably one will be more prominent in the next few years, and then maybe in the future the other will take over. But I think for now, the non-targeted therapies, meaning you don't have to know exactly where the seizures are coming from, you don't have to understand that patient's individual brain network. And I say that because right now it's a little bit hard to do that, and I think we're going to get better at that in the coming years. But right now, I think things like VNS and DBS and maybe TDCS to some extent are probably going to be a bit more applicable. But as we go forward and we get better at using TMS EEG and other non-invasive paradigms to measure connectivity and to interrogate networks, I think we'll be able to target that a little bit better. And even if it isn't even if it isn't using TMS EEG to then target TMS, maybe you can prognosticate a response. Maybe you can say, this child or this patient has a 20% chance of response or an 80% response to DBS or whatever it is. And that would be very useful information for families when making decisions. And something I think about a lot is where neurostimulation is going to end up fitting in the treatment hierarchy. Right now, especially with the advancements that have been made in the last decade in medication for Dravet, appropriately we think about neuromodulation when medications aren't working and when patients have tried a lot of those. But I wonder, as we get better at this, and hopefully we will in the next few years, I wonder if it might not be, maybe not first line, but second or third line for options. I mean, the other big advantage that I haven't talked about is that it's not a medication, right? These aren't things you have to take every day. So just to wrap up here, neuromodulation, hopefully I've convinced you, is safe. There's not a lot of evidence for it right now, but it's growing for Dravet. In particular, non-invasive or non-surgical brain stimulation. And as I mentioned, it should be considered when meds fail. So I'll stop there. I think I have a couple minutes for questions. Okay. Thank you. Anybody?
Great summary of all the techniques you described. I have a question, to my best knowledge, most of these techniques, they target in specific areas of the brain. And my question to you is, since in Dravet we don't know exactly whether there's any kind of focal area that is affected, how do you expect all these treatments to help kids with Dravet, since it's probably a network disease?
Yeah, so that's a great question. And I think there's a couple of potential answers. One is that you don't have to necessarily understand the network perfectly to perform, for example, vagus nerve stimulation. The vagus nerve stimulation, you stimulate the vagus nerve, and so we have data about that at least. It's VNS probably isn't as effective as some of the other devices that I talked about, and it might be because it is more of a generic target, so to speak. DBS, I kind of talked about it like it was a generic target, but it turns out, many of you may know, the actual nucleus that you stimulate within the thalamus probably matters a great deal. Most of the data is for this area called the anterior nucleus of the thalamus, even Dravet, that's where it's most often stimulated. And, but I wonder about some of the other thalamic nuclei that we've started to explore for patients, for example, with generalized epilepsy or with Lennox-Gastaut, if that might not be more beneficial. But I do think that probably the ideal for most patients is going to be able to interrogate their network in a way, or understand their individual network in a way, and then tailor your approach based upon that. Right now, it's very hard to do that. Anybody else? Oh, so it's very bright.
I just had a question on your experience. Are there any issues with risks of having the VNS in when it's no longer active? So it's been in for a while, so the battery is dead. And is it your recommendation that you actually then take the VNS out?
We often do if the patient, for example, has no benefit or just it's not working anymore. So it turns out often you can take out the device, but not the wires kind of get scarred up around the vagus, and it's usually not worth the risk to take those out. So that part tends to be permanent, but the actual the device is often removed. But oftentimes it comes down to patient preference. We don't see a lot of risk long term from the device itself. I suppose I didn't talk about this much, but the VNS has an expected battery life of 5 to 7 years, and that's what you're referring to. And after a number of years, either if it's not working, sometimes it's taken out, or it's replaced.